Hello and welcome everyone. Today we will be discussing an important topic, that is measuring patient's effort on ventilator. Optimal inspiratory effort is crucial for patients with acute respiratory failure on mechanical ventilation to prevent the diaphragmatic dysfunction and complications during the weaning period. Low or absent inspiratory effort can lead to diaphragmatic dysfunction, atelectasis, and hypoxemia. Intense inspiratory effort in turn can create negative alveolar pressures, potentially causing lung injury, that is patient self-inflicted lung injury, the PCLI, and diaphragmatic injury, that is the myotrauma. Even with seemingly spontaneously triggered breaths, minimal minute ventilation is delivered due to the nature of the assisted ventilation, often resulting in very low effort from the patient side. The switch from controlled to assisted ventilation may lead to uncontrolled vigorous efforts, especially in patients who were at the initial stages of their hypoxemic respiratory failure. So both lung injury and systemic inflammation are prime patients for PCLI and myotrauma through excessive loading. PCLI mechanisms involve excessive lung stress, increased transvascular pressures correlated with the intensity and timing of the inspiratory efforts. There is evidence that lung injury may also affect other organs, including the brain and the kidney. Monitoring the respiratory drive and the effort is advised to adjust ventilatory settings and sedation levels, aiming for protective measurement of both lung and diaphragm to enhance the clinical outcomes. This particular video details tools and parameters for monitoring the respiratory effort and recommends targets for managing the respiratory drive and effort. So coming first to the function of the respiratory muscles. The main function of the respiratory muscle is the contraction. This refers to the activation and the shortening of the respiratory muscles, mainly the diaphragm and the intercostal muscles. So this particular contraction results in a reduction in the pleural pressure. As the diaphragm contracts and moves downwards, enlarging the chest cavity, it reduces the pressure in the pleural space. The increased abdominal pressure as the diaphragm descends, it compresses the abdominal contents, raising the intra-abdominal pressure. Now, driving the gas into the lungs, the gradient between the lower pressure in the pleural space and the outside air causes the air to flow into the lung during the inspiratory phase. So, which pressures are to be measured? So, first we will discuss the invasive measurement, and then we will discuss what non-invasive methods we have. So first, to measure invasively the respiratory effort of a patient, we need to measure this pleural pressure. So this is measured by placing a sensor in the esophagus, because the esophagus lies in a very close proximity with the pleural space. Thus, we use the esophageal pressure as a surrogate of the pleural pressure. Now, we also need to adjust for the abdominal pressure. The gastric pressure here is used as a surrogate for the abdominal pressure, and it is measured by placing a sensor in the stomach. So what is actually done is we place a catheter with two sensors. One is in the esophagus and one is in the stomach. With those two sensors, we measure the pressures in the esophagus, which is surrogating for the pleural space, and the gastric pressure, which is surrogating from the abdominal pressure. Using both this pleural pressure and the abdominal pressure, we try to measure what is the effort of the patient. So what we have now with these two pressure is what is called the transdiaphragmatic pressure, the PDI. The definition of this is the difference between the esophageal and the gastric pressure. It specifically reflects the pressure exerted by the diaphragm, which is the main muscle of respiration. So mind you, it is not measuring the effort of the other respiratory muscles. It is mainly focusing entirely on the effort of the diaphragm. Now, what are the changes in the pressures? The delta PDI, this represents the change in the PDI from the end expiratory level to the peak during the inspiration and is a direct measure of the diaphragm's mechanical work. Now, this measures, that is the delta esophageal pressure, the change in the esophageal pressure from the mid expiratory level and reflects the collective effort of all the respiratory muscles. So the delta PDI represents the end expiratory work to the peak of the diaphragm, and delta PES, that is esophageal, reflects the effect of all the respiratory muscles. So what are our safe targets? Suggested safe target for the delta esophageal is to avoid excessive respiratory effort and insufficient assistance. The similar target ranges for the delta PDI, which is proposed to prevent the diaphragmatic injury from either excessive or insufficient workload. So what are the instrumentation that we use? As I have told, we use a catheter which is naso or orogastric. It is a flexible tube that can be inserted through the nose or oral cavity with sensors for measuring the pressure. A device is attached to the catheter when positioned in the esophagus and can inflate slightly to measure the pressure changes that reflect the pleural pressure. And how do we confirm the positioning? What we do is called the occlusion test. A maneuver is used to confirm the correct placement of the esophageal balloon by checking if the pressure changes in the esophagus reflect the change in the airway pressure during an effort against a closed airway. So delta esophageal to airway pressure change ratio, this ratio should be close to 1, between 0.8 to 1.2, to confirm that the esophageal measurements are the reliable surrogates for the pleural pressure. So this is how we try to see whether the change in the esophagus is correlating when we are trying to make significant changes in the pleural pressure. So what is the global respiratory muscle effort measurement? So the esophageal pressure time product per minute, this is a metric which is used to quantify the total work done by the respiratory muscles over a minute. It is considered the most comprehensive indicator of the respiratory muscle effort and correlates with the energy consumption. Now how do you calculate this? This is calculated by integrating or summing up the muscular pressure over the time of inspiration. It essentially measures the area under the curve of the pressure time graph during a breath. So what is PMUS? That is the muscular pressure. PMUS is the active pressure generated by the respiratory muscles, which is the difference between the esophageal pressure and the chest wall pressure, the chest wall recoil pressure, that is. So what are the factors that influence the chest wall recoil pressure? It represents the pressure of the chest wall which exerts to return its resting position after being stretched by the inspiration. So each chest wall, that is the elastance, is measuring the stiffness of the chest wall, how much pressure change is required to change the volume. That is, in ARDS, the chest wall is typically less compliant, stiffer, around 8 centimeters water per liter. So how do we estimate the pressure recoil of the chest wall? Ideal measurement, the PCW, should be measured when the patient is not actively breathing or contracting its respiratory muscles, that is in passive conditions. Estimation in active condition. For passive measurements are not possible. Estimations are made on standard values adjusted for the patient's age, height and gender. So what are the complexities? Now when the patient breathing efforts are out of sync with the ventilator, it actually complicates the measurement of the PTP. So if the expiratory muscles are involved, they can alter the esophageal pressure by affecting the baseline pressure from which the changes are being measured. So what are the recommendations? The recommendation of safe range for PTP per minute is 50 to 200 centimeter of water per second per minute, striking a balance between insufficient and excessive respiratory muscle workload. safe peak P muscle targets. The target range for peak P muscle is the more than 5 or less than 15 centimeter of water, and it is suggested to maintain effective respiratory effort without overloading the muscles, that preventing the fatigue or injury. Now, whatever we saw till now was the invasive methods. So problem with the invasive methods is it is very expensive, because these catheters are very expensive and the monitoring devices are also very expensive. However, we need to do this monitoring in almost all the patients who are on ventilator. So replicating that in studies becomes a very expensive effort. So what we are trying to find are surrogates or non-invasive measures which can help us in finding the patient's respiratory effort. So this monitoring assesses the output of the respiratory control center in the brainstem, and it dictates the initiation and strength of each breath, effectively controlling the inspiratory effort. The effort made by a patient to draw a breath in a mechanically ventilated patient can reflect the patient's spontaneous breathing ability and interaction with the ventilator. So these methods that we are going to discuss now are the non-invasive methods. The first one is the airway occlusion pressure, or P0.1. It is a non-invasive measure that gauges the initial part of the respiratory dive. It reflects the pressure effort by the patient during the first 100th millisecond after an inspiratory effort against a closed airway. Now, to measure P01, the airway is momentarily occluded at the beginning of an inspiratory effort, and the pressure drop in the airway is measured. This occlusion reflects the patient's attempt to breathe against a closed ventilator valve. Now, what are the interpretations? A value of less than 1 indicates a potentially low respiratory drive, which might suggest over assistance from the ventilator or sedation that is too deep. A more than 4, it suggests high respiratory drive, which indicates under assistance, inadequate sedation, and a response to metabolic demand or a respiratory distress. A higher P01 can also imply that the patient may struggle with transition from controlled to spontaneous breathing. This situation may necessitate adjustment of the ventilator setting, sedation, and further evaluation of the patient's respiratory mechanics and lung function. The next thing is the measurement of the occlusion pressure, POC. POC is the measurement of the airway pressure drop observed during a maneuver where the patient's airway is occluded at the end of exhalation. It captures the maximum inspiratory effort that the patient generates against a closed ventilator setting. The estimates. The POC is multiplied by a factor that is minus 0.75. It estimates the muscular pressure, which is the pressure exerted by the respiratory muscles during inspiration. When POC is multiplied by 0.66, it provides an estimate of the change in the esophageal pressure during unoccluded breaths, which reflects the collective work of the respiratory muscles. Now, what are the applications of these two things? P0.1 as an indicator of respiratory drive. P0.1 measures the patient's respiratory drive or the intensity of the neural signal triggering the breath. It particularly is useful in non-invasive monitoring. POC serves as an indicator of the respiratory muscle function by quantifying the pressure that is generated during an occluded breath. Dynamic transpulmonary pressure. By combining these measurements with the patient's ventilator positive pressure, clinician can estimate the dynamic transpulmonary pressure. This is the pressure gradient across the lung from the airway opening to the pleural space, which drives the ventilation. The measurements are used to adjust the mechanical ventilator settings, aiming to provide enough support to mitigate the risk associated with lung overdistension, which may lead to VILI, and also for maintaining patient's comfort and safety. So there are also variability. Averaging the P0.1 value can also be done. Due to the natural variation in the breaths, averaging 3 P0.1 value can provide a more stable and reliable estimate of the respiratory drive. This helps in minimizing the impact of transient factors that may affect a single measurement. The next is end inspiratory occlusion in assisted ventilation. The purpose is a maneuver performed at the end of mechanical ventilation to pause the airway in the lungs, allowing pressure within the airway to equalize with the alveolar pressure. It requires the respiratory muscles to be relaxed to accurately reflect the static condition of the lungs. The reliability. P-plat is evaluated by observing the pressure reading on the ventilator after an inspiratory hold. A P-plat is deemed reliable if during repeated measurements a flat P-plat is observed in the pressure tracing for at least 75% of the occlusive measures. This flat plateau signifies that the pressures have equalized throughout the lungs. Significance of P-plat. P-plat reflects the recoil pressure of the lungs and the chest wall at a given volume, providing information on the static compliance of the respiratory system. It is typically higher than the peak inspiratory pressure, which includes dynamic factors such as airway resistance. P-plat includes the pressure provided by the ventilator and any pressure contributing to the patient's respiratory muscle during the initial part of the inspiratory hold. A higher P-plat may suggest overdistension or poor compliance of the lung, which could predispose to VILI. Therefore, it is often targeted to be below a certain threshold to minimize the risk of lung injury. Commonly, it is 330 centimeter water in ARDS patients. The next and the final marker is the pressure muscle index. PMI is determined by subtracting the peak inspiratory pressure during the inspiratory phase of mechanical ventilation from the plateau pressure, P-plat. It represents what? PMI quantifies the additional pressure exerted by the patient's own respiratory muscles during a breath. If any, a higher PMI suggests that the patient is contributing significantly to the breathing effort even with the ventilator providing support. Now, PMI can be useful in assessing whether a patient is being over-assisted or under-assisted by the ventilator. Just summarize all thing that I've told with this example. It will be easier to understand. So this is a standard respiratory effort of a patient on the ventilator. Here, first we will discuss the invasive one, where we have the esophageal pressure. And the gastric pressure is not shown here, but we find the transdiaphragmatic pressure, the difference. This is the airway pressure, this is the flow. So, what parameters that we see? The first one that we will see is the delta esophageal pressure. This is the change in the esophageal pressure during the inspiration, shown here by the depth of the dip. This depth below the baseline, it is a negative value because it represents a drop in the pressure inside the esophagus due to the negative intrathoracic pressure. In this particular example, it is minus 13.8 centimeters of water. Okay. So the next thing that we calculate is the muscular pressure. Now the muscular pressure is calculated by the formula, that is the airway pressure minus the tidal volume divided by the compliance minus the flow multiplied by the resistance. This will give us what is the pressure muscular. So when you subtract these two, what you will get is the chest wall pressure, recoil pressure. From there, you can calculate the area under the curve, which will give us the pressure time product. This represents the work of breathing over the time. In this particular case, it comes out to be 10. So from here, the main two things that we try to measure is the delta esophageal pressure, the primus, and finally the pressure time product. Based on this, we find what is called the effort of the patient. So this is the example showing the non-invasive method. Here, as you can see here, we do an inspiratory hold, and as the patient breathes, it elevates the plateau pressure, and what we measure here is called the PMI, or the pressure muscle index. It is calculated during this inspiratory hold, and it represents the additional pressure generated by the patient's inspiratory effort above the set peak inspiratory pressure. In this example, it comes out to be 5.2. Now the next thing that we do is called the end expiratory occlusion, an occlusion which is done at the end expiration. Here you measure two important things, that is the P0.1. This is the initial negative pressure deflection measured in the first 100 millisecond of the occlusion. It provides a rapid assessment of the respiratory drive of the patient. it doesn't necessarily show us the muscle activity. It is showing us the respiratory drive. If it is too negative, then the patient is having a very strong respiratory drive, which means that we need to reduce it before we can plan to wean the patient. The next thing that we measure is the P-oc, that is the occlusion pressure. This is the total negative pressure swing generated by the respiratory muscles during a brief occlusion. In this particular example, it is minus 24.8 centimeters of water. From this, what we do is we try to estimate the P muscle, because that is what we are actually trying to measure, the P muscle and the delta ES. So to measure the P muscle, what we do is we use this formula 0.75 into P occlusion. So this will give me a rough estimate of the P muscle. And to measure the delta esophageal pressure, I will multiply it by minus 0.66. So basically, by using these formulas, I am getting a rough estimate of the delta esophageal pressure, the P muscle, the drive of the patient, and the muscle strength of the patient. So by using all these things, what I can do is I can see whether the effort is adequate or not, or if the effort is more or not. We need to measure the adequacy when I am trying to wean, and I am trying to see if the effort is more if I am in the early stages of the disease, where I want to reduce that work of breathing and prevent P-silly. So if the respiratory drive is less or the muscle strength is less, then probably I need more time to wean the patient. If the muscle strength is good and the drive is good, then I can slowly wean the patient. However, in the early stages, if my respiratory muscle use is more and my effort is more, then I need to probably sedate the patient or change my ventilatory settings in a manner to reduce the various parameters. So what is the take-home message? The take-home message is the respiratory monitoring in ventilator patient is essential to optimize the patient care. It helps in preventing VILI. The key parameters: P0.1, where a value of more than 4 indicates higher efforts. P-plat is a static measure of the lung compliance. High values indicate over distension. PMI reflects patient's respiratory muscle contribution during the support. And P-occlusion, which assesses the patient muscular efforts. Thank you for your patience.